Hello, my name is Jodeline Morales. I am a student at Berea College, majoring in Health and Human Performance. This video is made for Dr. Michelle Thornton's class, HHP 247, Team Sports. In this particular video, we will be talking about spondylolysis, what it is, we will have a pseudo patient, and we will be able to overlook the SOAP method. Spondylolysis is a stress fracture in one of the vertebrae, which are the small bones that make up the spinal column. Spondylolysis is the middle of a three-step reaction, the first being stress reaction, the second being spondylolysis, and the third being spondylolisthesis. Here is some anatomy that is needed to further understand this injury. The pars interarticularis will be found between the pedicle and the lamina of the vertebrae. Here is where you will see the stress fracture, which makes up the injury of spondylolysis. A complete break is spondylolisthesis. This injury can be symptomatic as well as asymptomatic. However, when symptoms are present, this can include persistent lower back pain, stiffness in the back or legs, hamstring muscle tightness. It is noteworthy to mention that diagnostics via X-ray will not always show abnormality with a stress fracture. The causes of spondylolysis are the hyperextension of the spine at quick rates causing repeated stress on the lower back. You can see this in many athletes including gymnasts, pole vaulters, interior linemen, swimmers, and divers. It can also be due to genetics in people with thin bones. Our pseudo-patient's background, Mireya Santiago, is a 28-year-old community league volleyball player. She is a middle blocker or a middle hitter. By playing in her volleyball league, she has experienced repetitive hyperextension of the middle and lower back. She says she has experienced pain before, which subsided, so she decided to leave the irritation untreated. Now that we have gotten to know our pseudo-patient a little bit better, we are able to overlook the SOAP method. S stands for subjective, which is self-reported sensations or feelings. Objective, reliably measurable or observable details. Assessment and treatment goals, in which the main problem is identified and we prioritize it in order to create goals. And a plan, which will be done to recover or continue recovering the injured patient. For subjective, Mireya reports that she feels pain in her lower back. As she describes this pain, it begins to sound like that of a muscle strain. When she bends backwards, she feels a pain that travels down her back and radiates down her legs. Her community league has games every weekend, but she practices almost every day. The patient explains that she took a week off to remodel her new home and to move. Prior to that week, she had felt lower back pain that went away during her time off. Upon returning, she decided not to hold back. This went on for 3 weeks, during which she continuously felt pain. She now feels an ache that never subsides. As for objective details, we are able to observe that our patient walked into the clinic slightly hunched forward. Her torso seemed very rigid, and her movement was very slow and less fluid than that of a healthy, normal being. Upon palpation, we were able to see that Mireya is point tender around the lumbar region, specifically around L4 and L5. We had her do a couple of active range of motion exercises, which included spinal flexion, extension, rotation, and lateral flexion. Spinal flexion was complete range of motion, but she did feel an ache. As for extension, her range of motion was limited and pain was present. Her rotation was also limited, and there was pain. Her lateral flexion was full range of motion, but again, she felt the ache. For our passive range of motion, we tested the same muscles with the same exercises and found that spinal flexion was full with an ache, extension was full with pain, rotation was full with ache, and lateral flexion was full with ache. Upon using these same exercises, we are able to conduct manual muscle testing, in which spinal flexion came out 5 out of 5 with pain, meaning that she was able to complete the exercise, but she did feel pain. Extension was 4 out of 5 with pain. rotation was 5 out of 5 with pain, and lateral flexion was 5 out of 5 with pain. These results showed us that extension was where she was most limited and where she felt the most pain. As for her assessment, a combination of scans and special physical tests can help confirm the assessment. Based on Mireya's results of the Michaelis test, spondylolysis can be confirmed. Michaelis test is where our patient is asked to stand on one foot and extend their back. You will have them again repeat the same exercise on the opposite foot. If the pain is localized on one side of the back, standing on the ipsilateral leg will cause pain. Our treatment priority goals, based on Mireya's results, is easing the healing process by encouraging increased blood flow. This will help the interarticularis stress fracture heal. We will minimize irritation by eliminating or reducing causation factors, which in this case was volleyball. We will include strengthening exercises in rehabilitation, reduce pain, and practice normal movement patterns. As for her plan, we have NSAIDs to provide pain relief, NSAIDs standing for non-steroidal anti-inflammatory drugs. We will undergo a conservative treatment through rest from causative activity, which again is volleyball, and we will strengthen and work on flexibility for her rehab. For her plan, we have included lower back exercises. For knee raises, she will raise her knee to her chest, hold for 5 to 10 seconds, and repeat with the opposite leg. Then she will repeat with both legs. This exercise strengthens the spinal extensors. As for abdominal exercises, she will be asked to undergo abdominal tightening, where she will try to flatten the lower back against the floor. She will hold this exercise for 10 seconds. For partial or full sit-up, she will raise the head to the chest while attempting to lift the shoulders off the floor. She will hold this exercise for 4 to 6 seconds. When there has been some improvement, she will try to raise the upper body further from the floor. As for the flexion chair exercises, she will be asked to sit in a hard chair with her feet on the floor and legs apart. Slowly, she will lower the upper body between the legs until a stretch is felt in her lower back. She will then relax and hold this stretch. Lastly, she will be asked to do leg raises. She will raise a leg, keeping the knee straight. She can provide assistance if necessary by grasping the ankle. She will hold the stretch for 10 seconds and repeat with the opposite leg. In bilateral straight leg raises, abdominal activity is minimal and there is no strengthening benefit. For those that are interested in preventative treatment, studies showed that by sitting and standing correctly, lifting correctly, and eating healthy is a good way to prevent spondylolysis. At the bottom you will see 3 different exercises that will also help in strengthening the lower back area. This includes planks, hip flexor stretches, and a modification of the dead bug abdominal exercise. This concludes my spondylolysis presentation, and here are my sources. Thank you.